Good afternoon, everyone. I'm David Savitz. I'm the chair of this committee, and I want to thank everyone for taking the time to listen today. As you know, this committee has been undertaking the task of reassessing the Airborne Hazards and Open Burn Pits Registry to offer the VA guidance on how to improve the data collected and with a number of specific details. And the full charge to the committee can be found on the project website, the webpage, where you'll be able to identify the committee members and obtain some additional details. Today we're going to have the opportunity to hear from Dr. Eric Schuping, the VA's director of the post 9/11 era environmental health program, and he's going to be presenting the VA's interest in the study and background about the registry, and mention some of the other data sources that address some of these same concerns. Then we're going to have an opportunity for the committee to ask questions with the VA representatives. And then following that, and we will have time for a number of members of the public to offer comments. When we get to the public session, the comment section, we will have the attendees. There'll be an ordering of those that have signed up. If you haven't already signed up and wish to offer comments, use the Q&A box to express that interest. I think, as you can see by the large number of people who do wish to speak, this is clearly an important issue to many veterans. And I think to manage the time and to make sure everyone has an opportunity to speak, we're going to limit the verbal comments to 3 minutes, and we will, if that is insufficient to share all the information you'd like to share, there is an opportunity to provide written material directly to the committee through by sending a written statement in as well. This is an open session, as you know, and but it's really for the committee to engage with the VA representatives, and there won't be an opportunity for the audience or the attendees to ask questions directly of the committee or from the VA representatives. Again, if you have information to communicate, you can contact the project staff and STICA or others that are involved with the project through email or through other means. Finally, I should note this is purely for the committee to gather information. We're not providing information at this point. We're very early, at the very beginning, in fact, of assembling the materials that we need in order to make an assessment and respond to the charge and offer recommendations. And so even if it sounds like by some of our questions that we have a point of view or a perspective or have drawn conclusions, that really is not the case. We truly have not drawn any conclusions yet. We are just beginning the process of gathering information. We expect to have a draft report somewhere around September of 2022, and at that point the report would be reviewed and by outside experts that the National Academies engages, and before it is released, it would be approved for that. And so just to get us started, let's go around the committee and ask everyone to introduce themselves. Again, I'm David Savitz. I'm a professor of epidemiology at Brown University School of Public Health. Maybe we'll just go in alphabetical order. Dr. Balmes?
Hi, I'm John Balmes. I'm a physician scientist at the University of California, San Francisco, and the University of California School of Public Health at Berkeley.
Thank you. Dr. Bell?
Hi, everyone. I'm Michelle Bell. I'm a professor of environmental health at the Yale School of the Environment with secondary appointments in the School of Public Health and Environmental Health Sciences Division, and also in the Environmental Engineering program. Thank you.
Thanks. Dr. Daniels?
Oh, yeah. Hi, I'm Mike Daniels. I'm professor and chair of statistics at the University of Florida.
Thank you. I probably should have rehearsed the pronunciation of Marianti's name, but Dr. Klumortuzoglu,
that was
you
very
can
well.
fix that. You can correct that, please.
Thank you. This is Marianne Fikri-Murzoglu, Assistant Professor of Environmental Health Sciences at Columbia University's Mailman School of Public Health. Thank you.
Thank you. Dr. Mukherjee.
Hi, everyone. I'm Brahmar Mukherjee. I'm the Professor and Chair of Biostatistics and Professor of Epidemiology and Global Public Health at the University of Michigan School of Public Health.
Thank you. Dr. Murphy.
Good afternoon, everybody. I'm Fran Murphy. I'm the President and CEO of Sigma Health Consulting.
Thank you. Dr. Olson.
Hi, I'm Kristen Olson. I am Professor of Sociology and Director of the Bureau of Sociological Research at the University of Nebraska-Lincoln.
Thank you. And Dr. Smith. Is Dr. Smith present? I have to look at my list. He may have had to step out for a bit. Well, I'll introduce him in absentia. Dr. Tyler Smith, who is a professor and statistical epidemiologist at National University in San Diego, California. Let's go ahead and I'll invite Dr. Shuping to, you may want to introduce his colleagues from the VA, but to proceed with Dr. Shuping's presentation.
Hello, Dr. Savitz. Yeah, the presentation has been pre-recorded, and when we're ready, we can play that.
Okay, I think so. And then again, as I said, I know there's others from the
Hello,
VA who are. Sorry, go ahead. We'll do the presentation. I'm sorry, I didn't mean to interrupt the talk. And then at the end, maybe we'll go through and see who all is here from the VA that involved with the registry project. So let's go ahead and hear it.
Hello, good afternoon. My name is Dr. Eric Shuping, and I work in post-deployment health services at the Veterans Affairs in DC. And I'm going to be doing the charge meeting for the Airborne Hazard Burn Pit Registry Committee to review or re-review the Burn Pit Registry. And this is what I'm going to talk about today. First, I will give the actual charge. And the Burn Pit Registry is a complex system, has lots of different parts to it. And I'll give you a high-level background of the Burn Pit Registry. I'll focus on the online portion and the Part 2 clinical exam. And then I'll share some of the data from the Burn Pit Registry. I'll then move over to some of our outreach activities and then other resources that may be helpful for the committee to review this program. So get into the charge. Some background on this, and this is actually in the statement of work and in the charge. Back in 2013, Public Law 112-260 established the Burn Pit Registry. And part of that public law they requested that the National Academies do a review of the Burn Pit Registry, which was completed in February of 2017. And the same law asked the National Academy to do a re-review, and that's why we are here today. This time has marched on, and we're going to request that the National Academy review the Burn Pit Registry again. So, specific elements in the law for the review. They want you to, of course, look at the initial report as a baseline, and kind of move that report forward, and essentially want you to do a program review of the Burn Pit Registry. How are we doing, and most importantly, how can we improve? Because what you do recommend, we will most certainly take to heart and implement. Okay, get into some of the specific elements of the of the Burn Pit Registry. Want this to be science-based and rigorous. that the committee review all the facets of the Burn Pit Registries, but really the goal is to evaluate burn pits and airborne hazards, exposure, and potential chemicals to potential diseases in veterans. And based on those reviews, we would like to have some of your recommendations on how to improve. The third thing is like you to, you look at previous published studies in science on other similar registries, and are there better ways of doing business? Or are there other data sets we can pull into? Data sets that may be helpful to the registry might be the ILR, Individual Longitudinal Exposure Record, and I'll talk about that briefly today. In the Millennium Cohort Study could provide some linkages to bettering the burn pit registry. Specific elements on the report. How did we do with the 2017 report? We still do have some gaps, and we'll of course talk about that. Can we refine and improve on those gaps? And most importantly, are there other things that we can do better to improve the registry? The 2017 did a data review, and we'd like for the committee to relook at that data, kind of do another analysis of the data collection, and let us know what you think about that. And I guess another question too is, registries in themselves have limitations, and are there better ways to be doing the the science on the association between airborne hazard, burn pit exposures, and disease? And another important question is, there's up to 4 million people who could be in the burn pit registry. We're at almost 225,000, today. We'll probably be at 250,000 by the end of the year. And what would be a good representative sample of this 4 million, population, where we can say we don't really need any more information at that point? Could there be a potential end state to the burn pit registry? And could there be something that could replace it? Is there a better way to get the intent of the burn pit registry with a better mechanism with less limitations, such as recall bias? Okay, I'm going to move into the background now. I've gone through the charge, and why are we here? And I think we all know that, but exposures are a concern to veterans and service members. They go to places with pollution. Many of the places they went to in Southeast Asia had burn pits. There's diesel fuel. And also other sources of pollution and inhaled toxins. So quite a few veterans. And this is a survey that was done in 2010. 1 in 3 said, I think I was exposed to a toxic exposure, and 25% of them think my health conditions are related to that exposure. So that's kind of the big picture of why we're here. I myself am a veteran. I deployed to Iraq, so I do personally share some of these concerns. Okay, what is the purpose of the burn pit registry? It was set up to improve our research efforts, and with that, help the claims process and ultimately clinical care. With the burn pit registries, we can send messages to everyone who's in it, our participants and registrants. For example, we sent out a message early in the COVID outbreak to let them know steps that they can do to protect themselves and accessing VA healthcare. And this information can provide clinicians essentially their exposure information. It's already recorded if they're in for clinical care or for their registry exam. So, kind of historical timeline of the burn pit registry. Back in 2011, a former National Academy, but the Institute of Medicine at the time, did a report on the long-term consequences of burn pits in Iraq and Afghanistan. This was published in 2011. Lots of concern from Iraq, up until that time when Iraq was closed. But probably the key point of this report is, you see the title is about burn pits, but the report suggested expanding your approach to burn pits and airborne hazards. And if I didn't mention this before to the committee, we want to be looking at all possible respiratory exposures, not just burn pits, but the pollution, local trash, diesel exhaust, and other exposures. Kind of moving on in time, the original law was published in 2013. which prompted the registry to begin in June 2014. So the first year was only 6 months, not a full year. 2017, National Academy published the first burn pit registry program overview with 9 recommendations. And in between that time, last year, the burn pit, Everyone Hazard Burn Pit Center of Excellence in East Orange, New Jersey was established, and they are kind of our key research arm, looking at exposures, airborne hazard exposures and disease. Okay, how does one get into the registry? Who's eligible? And it's really based on location. If you deployed to Southwest Asia after including Desert Storm, or Djibouti or Afghanistan after 9/11, you're eligible to join the registry. It's kind of illustrated on the map. Djibouti is another country that was added to the burn pit registry. And if you were in one of the seas surrounding the Arabian Peninsula, you are also eligible to join the registry. We mentioned eligibility, but there are people that are not eligible for the registry. And before talking about that further, pretty much, as I mentioned, pollution in places where our service member goes is very widespread. You pick any country and they don't follow EPA standards, so there's a baseline level of pollution. So being in the registry or not being in the registry doesn't mean there's no exposures. And also, more importantly, this registry is not linked or required for the VA claims process. They're fairly independent of each other. The claims people do not coordinate with us other than research and vice versa. One thing I would say, if you are in the burn pit registry, you can use that information to file your claim, but it is not required. But going back to the specific countries, we've had requests from people in all of these countries here to join the burn pit registry. And, Korea, Europe, and Bosnia. And once again, this doesn't mean you are not exposed and you don't have health issues. It means you can't join the registry. And the scientific reason for that is that the more people you put into a pool, the harder it is to discern a health effect from it. We call it scientifically regressing to the mean, and it's just not good to keep adding different people to the registry. However, we are very highly considering, or will add Syria as an eligible country. Sometimes it'll take a while to get that implemented. There's IT issues and issues with adding a country through the public notification process, but that is something we're planning on doing in the next year. Okay, the Airborne Hazard Burn Pit Registry is embedded in an IT structure. It is an online computer program, and last summer, or summer 2019, we put this registry into the Veterans Integrated Registry Portal, we call VERP, and this is a portal for registries, and it's one of 10 that you can see on the list here. There are 2 exposure registries, the burn pit registry being one, and then the embedded fragment registry is the other one within VERP, and that gives us a common platform to work with for quite a few of the VA registries. Within the VERP, you have a sustainment team, and they maintain the registry. They keep it working, kind of day-to-day things. But anything you want to change or improve that requires writing code, you have to go through a development team, additional team, and a IT request development process to make those improvements. We do have a current development team that has been working on the registry, and they have focused on operational reports that make it better for veterans in the field level. Our facilities can pull up action lists of veterans in the area who may need an exam. In the future, and we actually have a request in there, is to allow service members to add deployments. So, right now there's somebody in Afghanistan who'll come back and they'll want to join the registry, and it's very possible they'll deploy again and maybe even again. We'd like for that person to be able to add each of their deployment segments to the registry, but as of right now, they can only do one. The analytics is done in the Vinci, workspace. This is a common VA platform that the burn pit registry portal migrates into Vinci, where we can link it up with health records and other databases too. So burn pit registry, there's a lot of moving pieces as far as the IT structure that may be hard to appreciate unless you start looking into the system. Okay, let's get into the burn pit registry itself, and it's a two-part process. The first part is an online registry that you can do from any computer, and I'll talk about the process of getting in and how it works. But once you log in, you'll essentially do a questionnaire, and this takes about an hour. We originally posted about 40 minutes, and yes, if you had kind of a limited deployment, a short deployment, the computer is working perfectly, it would take 40 minutes. But the reality is, some people take more to an hour, some people may take up to 90 minutes. But it is an investment in time for the veteran to get through all the questions within the within the online portion. VA has other exposure registries. I mentioned, well, Agent Orange and the Gulf War Registry, may come to mind. And this registry is very different than those two because it is online. It's leveraging IT to do it, while the other two registries, you have to go in for the clinical evaluation, and that is the part two of the burn pit registry. Once you finish the online portion, you're eligible to come into a VA facility and get a evaluation, based on your exposures. This is voluntary. We felt that some people didn't want to, go in to see a healthcare provider about this, but the online is just a way to, record their exposures and be part of the, the survey. But, we do recommend and allow for anyone in the registry to come in for that part two physical examination. Okay, I want some details on the online portion next. And how does it work? Step one is logging in, getting into the system, and there's a secure portal run by DMDC, which I'll talk about a little bit below. And this is available to both VA and DOD, and essentially a secure platform that you can get to a lot of different databases, including e-benefits, which will have a veterans benefit information. So the firewalls are good and secure for a variety of reasons. You don't want people getting into this system, kind of easily and haphazardly, unless they need to. If you're in the service, you can use your common access card that all service members have to access. But for veterans, you pretty much have to rely on a password, which often needs to get updated and that sort of thing. So that can be sometimes a source of frustration for people. But the firewalls are there for a very good reason. Once you're into the registry, the next step is to sign a consent that you're providing your data and this will be available for use. And some people choose to not go any further, and that's, of course, their choice. And I'll show you kind of the different categories on a future slide as people go through the registry. But anyway, after you do the consent, for most people, but not all, your deployment information is linked up through DMDC. There's linkages with the directory that can say you went to Iraq at this time frame, and it's actually fairly detailed. I'll give my personal experience in there. I went to Iraq in 2006. I started off in Kuwait, and there was a time period from Kuwait. I filled out a question for that, and then I went into Iraq. I had a time period there. I went on R&R. I was back in Kuwait. So it's sort of back and forth. So for my deployment, I had 4 or 5 different segments, and that's how the registry is set up. Some people don't have that automatic linkage, and I'll talk about how that works out for them too, so they can join the registry. And actually that is the next bullet point. If that automatic linkage doesn't happen, and this is fairly common for the Desert Storm Group, for Special Forces whose information tends to be classified, and those have recently redeployed in the last 90 days, it takes some time for the information to go through DMDC. We have a process where they can send us validation of their deployment, such as a DD-214 or their orders. Once you get through all this, and it can be pretty quick for the automatic process, you can start answering the questions at that point. Okay, if you go to this website, and this is where you started, DS Login Sign In, you click there, and there's some other information in here that can be helpful to the veteran, answering questions, and why do I join? And if you notice in the upper right-hand corner, this is a kind of a ticking count of the number of participants. Participants are those who finished the registry, and this actually is updated in real time. I've looked at it several times during the day, and sure enough, it keeps sort of bouncing up. Okay, talked about the different categories, and the first is no consent. So as of October 13th, and that's when I ran this data, and this data was pulled from the portal itself, not from the Vinci Analyticals. The portal has some small analytical capability, but mid-October, 18,000 people cumulative over time did not consent, and they go into that no consent bin. Any of these people can change their minds. If they decide they want to come back to the registry later, that's completely okay to do so. Then the group that is not eligible, they get put into this bin. If they don't automatically deploy, or they have not provided DD-214, they end up here. You can't really come back to this if you haven't gone to a eligible country. The next group is eligible, and these are people who've started the registry but have not completed it. And then where we want to get is to the participants. These are the people who've completed all the questionnaires and have finished it. And this mid-October is run a little while ago. This can of course be updated, and the overall percentages don't seem to change over time. There's roughly, for every 2 participants, there's 1 person in the eligible category. Okay, this slide goes over the main category sections of the questionnaire, and I know the committee has a data dictionary which will give all these questions in more detail, the sub questions. The other piece of information within this slide is these are all the people who started and did not finish, and where do they stop? We were wondering if a particular question or area was keeping them from moving forward. And interestingly enough, over all the people who didn't start, 38% of them didn't answer any questions at all. There's really no information on them. Then you go to the next category, which is deployment history. This is what I mentioned, the Kuwait into Iraq, back to Kuwait. Some people tend to stop there. And then the further into the registry you get, the less likely you are to not finish. If you get through, you start the question, you finish your deployment history. Most people end up finishing the registry after this point. Okay, number of participants per year. You can see the bar chart per year. We've had high years. 2016 was rather high. 2018, 2020 is already the 3rd largest year. And it's going to grow, but it won't surpass the other 2 years. But we roughly get about 500 new participants a week. So some weeks higher, some people low, and these tend to be driven by external events, which I'll cover in another slide. Okay, moving on to more details on the Part 2 voluntary clinical exam. And how does one get a clinical exam? Well, when you become a participant, when you finish the online portion, you get a automatic email with instructions, and you also get a follow-on letter with the same instructions. And if you're in the VA or veteran or separated or retired, or if you're in the Army, in the Reserves or National Guard, you can see a VA facility for the exam. Those on active duty should go to a military treatment facility, and I'll talk about that in a later slide. But what we like people to do is to find their local environmental health coordinator. Depending on where you live, you click on the state, and the facilities offering the exam will kind of pop up, and it'll give you a POC at that point. So we encourage all veterans, if you want to get the Part 2 exam, please contact your local environmental health coordinator to help arrange that. It may not be done in their clinic, but they will get you in the right direction to get the exam done. Okay, I want to move on to some of our data, and we could talk a lot about this. And I'm only going to show you, one slide, and I would refer you to what we call summary of self-reported registry data, and the URL is there below. And we've posted 4 reports that have key demographic data and other information about the registry. I think that'd be a great starting point for the committee to look at. And this is the example of some of the data. We got our age distribution. Fairly young. With the mean and median in the 40s that you can see here. These numbers tend to stay fairly stable. They don't change. The percentages don't change. From report to report. And some other facts. For who our participants are. We do have some Gulf War veterans. A high number of them were around burn pits, which is a point of recruitment, because once again, this is not just about burn pits, it's about other exposures too, even there weren't burn pit around. A number of people, over half, actually worked with burn pits out there burning trash or being really close to them. And I think another common thing about our group is most of them were near an IED, implying that they were in active combat or most certainly in harm's way. So that's another characteristic of our participants in the registry. Okay, the registry itself, it changes over time. Everyone who's active duty, Guard, or Reserve will be separated or retired at some point, and the registry tracks that. It's not in real time, but as records get updated, this information will get updated within the registry. And this is another report pulled from the portal itself. And over time, people will pass away, and that also is tracked within the registry. This is done by a linkage with the National Death Index that's set up in the registry. We only get that a death has occurred and not the cause, but we can link that up through other data sources. And we have found that this group of the deceased, many of them are from suicide, MVAs, and other unfortunate events that happen, with a younger population. But of course, some people in the registry have had cancer and other medical illnesses too. Okay, I want to talk about some of our outreach activities. How do we recruit people, let people know about the registry? Well, first and foremost, everyone leaving the service since 2018, they're briefed about the Burn Pit Registry as part of the Transition Assistance Program, the TAP courses. It is one piece of information among many within the VA portfolio. The separating people get a lot of information, but they are told about the Burn Pit Registry. And then we have other communication products on our website. We have videos on our website that explain why someone should join the registry, social media posts, and other things. Our registry page is actually fairly well visited. People are interested in it. A podcast was done almost a year ago in March of 2020. That it was done earlier, but posted in March of 2020, and that's available for listening. We work with veteran service organizations, and the VFW, Veterans of Foreign Wars. They periodically send out a message to their members to join the registry. So thank you to them for assisting this. And DoD has been very active in promoting the registry, recruiting people. They sent out 800,000 letters last March, April timeframe. encouraging people to join the registry, and we most certainly got a bump. I mentioned the 500 per week, but we were 1,000, 1,500 for about a month after that. And they also have it embedded into LESs twice a year, so service members will see that also, and we get a little smaller bump with that. One thing that does happen is this is brought up in congressional hearings and media articles, and when there's a hearing and media coverage, we most certainly see a bump. And we all know John Stewart, and he he's a patriot. I love the Daily Show, but most importantly, he's been an advocate for burn pit exposed soldiers, as of course the World Trade Tower people. And when he talks, people listen, and we inadvertently get a bump in numbers when he's in the media, talking about burn pits. So thank you to John Stewart, for that. Probably the biggest project we got going on, we're going to be updating the website. We've had a contract to essentially improve our outreach about the burn pit registry, and we're finally getting to the point that we're going to have some deliverables. We did some focus interviews, and we'll have some focus groups early next year, and this is of course information that'll be provided to the committee, what they found. But later this month you'll see our current website will change, and hopefully it'll be easier to read and more clear. In this, I want to talk about kind of the specifics of our contract here, and there is a lot of good that the VA can offer, and that would be getting benefits, getting health care for burn pit exposures and really any exposures, and we're trying to make that information more clear to veterans when they do come to our website, and of course we want them to join the registry too, but we're hoping we give them more information than just joining the registry. Okay, I'm going to kind of highlight some of our other resources that are available to the committee. And first of all, you should be aware of the Airborne Hazard Burn Pit Center of Excellence up in East Orange, New Jersey. And these are their 4 pillars that they work on. And these are some of the things that are pertinent to the committee. They started a research project called the Post-Deployment Cardiopulmonary Evaluation Network. What this is, they're taking people within the registry that could potentially benefit from a more extensive workup, and they've been actively recruiting these people. They're improving their access and veteran experience through a program called iQuest. And what this is a secure portal that veterans can put their information into, that people within the VA system can access to help them with care. And this is really coming to the forefront of COVID when it hasn't been safe to go to the facilities. So the Center of Excellence has been very embedded and worked with iQuest. They're involved with ensuring our data quality and integrity is good, just kind of oversight and reviewing the registry. And really overall goal is to promote, advance the scientific knowledge of burn pit related, airborne hazard related concerns. Another resource, and this is certainly worthy of a whole lecture, and that would be the EILER program. And what EILER does is essentially is a compiler. It takes exposure information collected in DoD from various different sources, and it can put it together that a clinician or a claims manager can pull up for clinical care. It's also useful for research purposes too, and it's being configured to do such. So one weakness in the whole science of exposures and disease is knowing what exposures actually happen, and EILER is kind of the mechanism to make that happen in time without having to pull special records and going through a lot of effort to get exposure information. One key issue with this, there's some, but not much, individual exposure monitoring. It's mostly area monitoring, so putting a person to a place and a time. And that's been one of the key things that's been worked out with EILER, that you know where a person was at a particular date. and having that available exposure information. And again, most importantly, this is going to be translated into research, down the road. And when you're in the ILO program, you can search by an individual or a location, and there's way more to talk about ILO, and that would be another lecture at another time for the committee. DoD is a very active partner, and we work with them all the time. And they recently posted their website. This is definitely worth reviewing and looking at to see what they're doing in terms of airborne hazard and burn pit registry enrollment and clinical exams also. Let's see. I want to talk briefly about the 2017 report. I've hit on some of the findings, and these are two that are very important, and we want an outside group to take a look at it. And we essentially have a contract that is being put out for bid right now, and sometime next year we'll have a group that will come and review the registry. Would have been ideal to have had it earlier, but due to a variety of reasons, it'll be happening now. And as we get information from them, this will be provided to the committee also, for their consideration. Some other, smaller but still important sources of information. We have lots of training videos, on-demand classes, webinars, and other things focused for environmental health clinicians, or really any clinicians doing environmental health work, and for the field coordinators to leverage the registry to do the burn pit registry exam, and we can make those resources available for you. I mentioned the contract, doing the individual interviews and the focus groups. That information should be made available. As mentioned before, the Burn Pit Registry portal has reports and information within the portal itself, and that would be worth a look to get a feel of what the staff has available for them to look at. There's also a practice module that you can get in, and there's essentially a fake veteran that you can log in as him, and you can see all the questions that they see as they see them too. I know you'll have an analytical team, working for the committee, and we can pull a data set for them with the Burn Pit Registry data. And I want to point your attention to the American Thoracic Society. They have a really good fact sheet here on burn pits and airborne hazards. Well, I've gone through a lot of information here, and hopefully, we give them the charge, and giving you a lot of different informations, and it's really kind of a facets and high-level overview of the different pieces of the Burn Pit Registry program that may be useful for you to do your review. And really want to thank you in advance. We're looking forward to getting the report down the road, and I will close here, and there may be a few comments from our staff, and we'll go from there.
Very good. Thank you very much, Dr. Shuping. Very helpful presentation. I wasn't sure if you wanted to offer any ancillary comments or hear from your colleagues, or we should just go right into the questions. You're muted, Dr. Shuping.
Yeah. Hello. Yeah. Thank you. I think we'll just introduce ourselves. There's four of us here, and we're really the spokesperson today. You hopefully got a sense from the lecture. It's kind of weird hearing yourself speak to yourself, but there's lots of people involved. There's lots of people, and these are the spokesperson today. And for the committee, I'm Dr. Eric Shuping. I've been with the VA 2 years now, 2 years and a little bit longer. I'm a family physician and an occupational medicine physician, and I'll be your main contact with Ann, to provide information. And we really thank you in advance for taking this on too. And at this point, I'll turn it over to Dr. Hastings. And I do have two comments. I misspoke a few things. I said 250,000 by the end of the year. That's not 2020. That would be 2021. We'll hopefully get 225,000. Also on the eligibility is the C's around the Arabian Peninsula too. That wasn't highlighted too. So I don't want to skip the Navy people who are in the registry. And probably the big thing is this is just kind of a menu of different ideas and stuff. You know, you can take a slide and we could do a deep dive on it, but didn't have the time today. But you know, upon request, we can touch on lots of other things. And let me turn this over to Dr. Hastings for her introduction.
You're muted, Dr. Hastings.
There we go. Thank you again so much, members of the committee. Very much appreciate you looking at the registry itself. This is something that is congressionally mandated. It is something where we are mining it for the information that we can get. It does have some areas that could improve, so we could use it more effectively. We'd also like your thoughts about the individual longitudinal exposure record. But again, thank you so much for taking this on. We look forward to your report. Thank you.
Thanks.
Dr. Schneiderman.
Hi, good afternoon, and my greetings and thanks to the committee. I'm the director for Epidemiology Program, Post-Deployment Health Services. I work with my colleague, Dr. Shuping, for Dr. Hastings in post-deployment health, and am here to support the committee's inquiry today. Thank you.
Thanks.
Hi, and good afternoon. Thank you, Dr. Savitz, for the opportunity to comment. Mike Falvo, I'm co-director of the VA Airborne Hazards and Burn Pit Center of Excellence. Work closely with Dr. Shuping and colleagues at PDHS and look forward to the outcome of the review. Thank you, sir.
Good, thank you. I'm asking now the committee members who have an opportunity to ask questions to use their raise hand function, and we will be getting help from one of the members of the National Academy staff to call on us. I have a hand up, but that's I guess I can call on myself if you want, but let me go ahead and get it started. But again, I'll ask the others to sort of field the questions. There are a number of, again, it's very helpful in trying to scope this out. There are these various sort of dimensions to the project. And one, of course, is in terms of the exposure information and all that follows from it, the degree of emphasis on the burn pits themselves in relation to the other airborne hazards. So obviously, we've talked about their particulate matter, there's diesel exhaust, there may be a range of other forms of airborne hazard. And I wasn't sure in the scope of our work how much should be done. So you could ask, for example, let's say if you're looking at alternative ways of collecting the data or ways of validating the data, it might go down different paths if it's the burn pits themselves, say, versus the the ambient particulate levels or things of that sort. It seems the bulk of the emphasis, of course, is on the burn pits themselves, but I wonder if you could sort of clarify the interest in the other forms of airborne hazard.
Sir, if I could comment, and then I'll ask Dr. Schneiderman, Dr. Shuping to also comment. You're absolutely correct. The burn pits are a grave concern for the Congress. That's where this started from. But the particulate matter in the environment is also important. And one of the things that we would like you to look at is the individual longitudinal exposure record, which does have some monitoring included in it, as well as being all the service members and their locations, and what your thoughts would be on that. Because with regards to EILR, not only do they put a person at a location during a certain period of time, they also are monitoring the environment, putting those into the EILR, the individual longitudinal exposure record, along with fact sheets regarding the monitoring and what the exposures have been. So you've hit the nail on the head. How do we match a self-reported registry, or can we, or do we need to move to something else? And at this time, I'll turn it over to Dr. Schneiderman and or Dr. Shuping for more comment.
Thank you.
I guess I would just add that it is the totality of the environmental exposure experience in a variety of scenarios that might be encountered during deployment that contribute potentially to health outcomes. So it would be constraining to try to limit the review to burn pits themselves, but here we're really looking at the utility of the registry. But I think we need to consider the total picture, as IOM pointed out in the 2011 report. Thank you.
Yeah, Dr. Savage, I don't have anything else to add.
Okay.
And if I could, this is Pat again. With regards to the Airborne Hazard Center of Excellence, where Dr. Falvo works, they are looking at some of those issues with regards to the burn pits themselves, as well as the issues of particulate matter, and to include studies of the dust, sand, and particulate matter in the air in different locations. So they may be able to give you some direction or some information there as to what they've done. Over.
Thank you.
Sure, thanks.
Dr. Balms? Oh, sorry.
Oh, I didn't mean to cut off Dr. Balms. I'm sorry, Dr. Balms. Go ahead. I can add to that later.
Yeah, I'm going to ask you something directly, Dr. Falvo, but first I wanted to ask the group of VA participants a little bit more about Eiler. So is there automatic linkage between participants in the registry with Eiler, or is that a separate step that you have to go through? Anybody?
Dr. Shuping can certainly answer this. He is the person that is working on this directly with DoD, because this is a Department of Defense and a VA joint project. It's very exciting because I do think it will change monitoring in the future. It has pretty good data from about 2010 on, and it's been able to have direct feed with some limited monitoring since about 2002. There is not a direct linkage at this time, but we are doing some testing to see what we find when we link people that are in the registry with the Eiler, to see what we find. We are going to take Eiler, and it is going to be linked with the electronic health record. The benefit there is it will be information immediately available to clinicians, researchers, as well as the claims and benefits people. But right now they're not linked, but that's one of the things we're interested in looking at, and you might explore.
And I also would ask, has there been any attempt to validate the self-reported exposure of the registry participants with Eiler data?
It's in its infancy. We have not attempted to do that in any large scale. We've done it on small basis just to see what we're finding. Right now, it's so early, we really don't have any findings.
And then specifically for Dr. Falvo, I know that the Center for Excellence has been bringing people in to participate in research studies. Have you done any sort of, because you have a chance to do more in-depth questioning of the participants, have you done any work with Eiler versus the self-report, more intensive self-report that you get when you see patients?
Thanks, Dr. Balms. With respect to Eiler, no, that's not a specific area of current research. But one thing where we're trying to expand upon the veterans' self-reported information within the registry is to collaborate with our partners within VA. As I'm sure you're aware, there's a large cooperative studies program underway currently. That includes, that's headed up by Dr. Garshik, Dr. Blanc, among others. So Dr. Shuping, I think, mentioned the post-deployment cardiopulmonary evaluation network that was listed there. So 4 VA medical centers. We're trying to utilize the resources in that approach that the cooperative studies program takes to enhance the location information as well as the exposure information. So that is an active effort. Yes, sir.
Oops, sorry, I muted myself there. Do you have any information from that 4 VA cooperative study so far, even if it's preliminary?
It's a great question. So we got established in May of 2019. We started arranging these 4 VA medical centers towards the end of 2019, early 2020. As I'm sure you can imagine, we are far below kind of where we'd expect to be right now due to COVID.
Okay. Well, as you probably know, Paul Blanc he's actually my boss at UCSF, so I know him very well. And I know Dr. Garcia too.
Dr. Daniels?
Yeah, so I had two questions, but one of them already got asked by John there. So the other question I had is related to Eiler. Is that currently like easily linkable to everybody that would be eligible for the registry? Or is it kind of at this point just for those that actually kind of completed the questionnaire in the registry to get an idea of kind of what might have been going on with kind of everybody in the registry, everybody that was eligible for the registry, I should say.
Absolutely. Eiler is a direct feed from the Defense Manpower Data Center. So it is every single service member that is going into it with their locations, the time frame that they were there, the unit they were with, as well as the monitoring that was done there. So Eiler will be even more robust as we get into new technologies like wearable monitors, et cetera. Of course, we don't have those now, but they are not linked to the registry at this time.
So if I could,
go ahead.
Sorry.
No, please.
So the initial operating capability for Eiler is for individual inquiry to support clinical care and the development of claims for the Veteran Benefits Administration claims adjudicators. What is under development now is a population level inquiry tool that would serve epidemiology and research as well as policy folks, for example, in the benefits side of the Department of Veterans Affairs, where we could in fact pull up cohorts of individuals or subgroups of individuals who might have things, characteristics upon which we could link. So we have started to work in the background to see if we could work with what's available to link different data, but from an automated perspective, that is not yet available. But I'd say that would be a future state. So we certainly appreciate that nascent recommendation there.
Okay, so short-term wise, it wouldn't. Yeah, that's not going to be feasible. I would say, i.e.,
probably
kind of the time frame of the study, for example. Yeah. Okay.
No. Yeah.
Okay. Thank you.
Dr. Savitz, back to you.
Yeah, no, this is maybe, again, just clarifying some of the points we're raising here as we talk about these other data sources. For our purposes, should we consider the registry is literally just what the registry contains? I mean, we can talk about potential for linkage or even complete alternative pathways or approaches to doing the kind of surveillance. But in sort of examining the registry, I take it that does not include Eiler, it does not include VA healthcare data. It is the information that is in that form, in that web. Is that the way you're thinking of it, at least as we try to sort of organize our comments?
What I would like is, you're absolutely right, the registry stands by itself, and so looking at the registry as it stands is important. But because Eiler is being built
Yes.
and in its initial operating capacity, starting to go out to the field, we'd like to have the National Academy evaluate the strength of that. The registry, the Airborne Hazards Registry, will have a day that it sometime ends in the future. It will have outlived its usefulness. And we'd like to know if Eiler could take the place of that. We believe it can, we believe it will be more powerful, but we'd like to have your recommendation, your thoughts as to the potential for Eiler versus a registry such as it is for airborne hazards.
Okay, and again, just to follow up on that, there are a number of other data sources that are mentioned in the charge, but it sounds like you're suggesting Eiler is kind of maybe at the top of the list of those mechanisms that we would do well to take a close look at. I don't know if there are others of that sort of stature. You mentioned the Millennium Cohort as well as another, at least an illustration of the kinds of other data.
Absolutely. Eiler would be the one that we could give you a separate briefing, a separate review, so that you can see how that works. But that would be I hesitate to use the term registry, because it is a record, almost like a personnel record of where people were, and also the monitoring that was done. We believe that it will be the future, and that thus it's being linked into the electronic health record, as Dr. Schneiderman said, for patient care, for claims and research in the future, which we are not able to do with our current registries in that manner.
Thank you.
Dr. Balms, I think you have another question.
Yes, thank you, Ann. So I appreciate that you're wanting to emphasize how Eiler could be very helpful with regard to exposure of deployed veterans in terms of airborne hazards and open burn pit emissions. Given that Eiler is a Department of Defense, I guess you're cooperating with the Department of Defense, but given it's a Department of Defense tool, because the exposures are occurring while people are active duty, how well is the collaboration with the DoD going with regard to Eiler? I only say that because this is about the fourth National Academies Committee I've been involved in with regard to exposures of deployed veterans in the Middle Eastern theater. And in the past, there have been issues about, responsibility, authority. And so I just wanted to know how well the collaboration is going with regard to DoD in general, Eiler in particular and DoD in general.
We are working very closely with DoD, as noted, it is a joint project. We have not had a problem with accessing the Eiler, and in fact, it is all on the other side of the river right now, on the DoD side, because it is in development. But they have given us full access to it. So once we take the training, which is on the VA side, we have our own training, the DoD gives us direct access to it. When it is fully up and running, it will be one where we have access with our own VA credentials. So it'll be on both sides of the river, so to speak. But they have given us full access. We have not had any difficulty in accessing. And in fact, Dr. Shuping right now, and I'll let him comment on this, has he's making sure that every single VA medical center has at least one person who is competent to get into Eiler so they can assist veterans even now, and also help other clinicians if they would have questions about exposures that that person may have had. So Dr. Shuping, would you like to comment on that also?
Yeah, absolutely. I work with the program manager pretty much daily. Part of it is with the access issues. People run into problems and we troubleshoot them. So yeah, I know the program manager on a first name basis. And kind of case point, I gave a lecture earlier today on Eiler. We have a monthly webinar series. It was available on this platform, Train, so DoD was on it. They kind of used the opportunity to hear the VA lecture about Eiler, because it's really both our program also. So our collaboration is really great.
Okay, if I could interrupt, I don't want to. I see Dr. Murphy has a question, but I think we know that Eiler is important, and we will definitely be bringing it up in some detail at a future session. I just want to make sure we have an opportunity to query the charge itself today, as this is our primary shot at that. I won't say it's the last shot, but it's the main opportunity we have. I saw Dr. Murphy, again, I don't want to intrude on the sequence here, but if I think, why don't you go ahead and then we can pick it up from there.
No, David, please go ahead if you had a question.
No, I didn't. I was done. I was just, I didn't want to cut in front of somebody else who had their hand up. So why don't you go ahead though?
Sorry. So thank you for coming to talk with us this afternoon about the charge for the committee. It's been very informative so far. I was wondering, sometimes it's hard to get access to VA and DoD data, and one of the charges that we're asked to look at is to define any or identify any associations. And it's going to be difficult to do that without getting access to a number of VA data sources, including electronic health record data and potentially claims data. Can you tell us if you can give the committee access to that kind of information in a timely way so that we can carry out our charge? And number two, are there, do you have a list of data sources that you would recommend we access?
And Dr. Schneiderman, I'm going to ask you to comment on this since it specifically has to do with data, but we've had discussions here in regards to that. And the data that is in the registry, we want you to have absolute access to. And I will talk with, or ask Dr. Schneiderman to talk about the other issues with regards to data and how we can meet that need.
Thank you for the question, Dr. Murphy. We have talked about this with regard to how we can help you satisfy the terms of the charge to the committee. You know, clearly the first thing that's outlined in the charge is the data that's in the registry, as Dr. Hastings said. I think any further access or articulation of data sources would probably have to be elaborated in a later discussion. I think we can probably come up with a list, as you have suggested, that might list or enumerate the data sources that would help you once we have a good idea of what your questions are and how you want to prosecute that charge. I hope that's helpful without feeling too evasive. There is a world of data within VA's walls. We don't necessarily have full access to all of it either. So, you know, sometimes the process of delivering data is a series of gates that we have to go through on our way to even finding our ultimate partner, in this case, the Academy or their contractors. Over.
A related question, Dr. Schneiderman. How do you determine the denominator of eligible veterans for the registry?
That's a great question, Dr. Murphy, and one that we reckon with on a regular basis. You know, we are customers within VA of data that is delivered from DoD. So like others at VA, we try to deal with those data sources. So for example, DMDC is the provider of data. They give us in those data feeds information about deployment status, deployment characteristics, service characteristics, et cetera. And from that, I think we seek to enumerate the number of people who've deployed with a country of interest. You know, usually with a lot of the work that goes out of our office, it's really deployed or not deployed under the contingency tracking system umbrella. But for purposes of understanding the people who would be eligible for the registry, it may have to go down to the level of country to be sure that we're actually developing the right denominator. The vast majority, of course, have eligible deployments, but we know that that might not be everyone from some of the work we've done lately.
Thank you. Back to you, David.
Other questions from the committee? I'm gonna.
Well, I have.
Go ahead, please. Go ahead, John.
And I don't. If this is tangential, just cut me off. In addition to working with the DoD in terms of EILR and, you know, the DoD also has health information on deployed deployed personnel that I think would be useful also for trying to figure out if there were any acute respiratory effects of deployment. in areas with airborne hazards, open burn pits. Is that something you've explored at all in terms of working with the DoD to enrich the registry?
Not at this point in time.
Is that something that you think would be of utility if you could pull that off?
Absolutely. In the future, that's one of the plans is we are looking at discrete cohorts such as Karshi-Khanabad and a number of others. And we have the majority of the health information on veterans. They have, of course, the majority of health information on the service members. And we are going to be blending those, looking at, in this case, Karshi-Khanabad, in other cases, different cohorts. So absolutely, it is something we need to do, but we aren't there yet.
Okay, thank you very much.
Watching the time, I'm going to take the chair's prerogative, I guess, and ask sort of what is maybe a kind of a summary sort of question. But in looking at the last part of the charge, the question is basically a potential end state to the registry when it has fulfilled its mission. If it has, or there's alternative ways. I don't know if you'd be willing to commit to a succinct listing of we would know we were done when we had sources to do. It's really getting back down to the fundamental functions of the registry that we will be able to consider one by one. Of course, it may be essential for purpose A and not for purpose B, but if you could sort of give a sense of what would be the goals that would, if fulfilled, if completed or fulfilled in alternative ways, I guess, would say that it's outlived its usefulness.
Right, absolutely. There are a number of parameters we would look at. One would be, do we have a large enough body of individuals that we would be able to study into the future? Another would be, is it not useful to have anymore? And this was one of the questions brought up earlier. Would it be not as useful because there really are no burn pits that are being used in the theater of operations now? Most of those were converted to incinerators in most cases almost a decade ago. There are, I believe, 9 right now that are still burn pits because of location. The other is when the conflict ends, would we close the registry and have it only open for people that have a proven deployment from the time frame that is delineated? So those are 3 that we would think, would it be something that would not go forward into perpetuity because it has met some certain mark or parameter? And at this time, I'll ask Dr. Falvo what, if the Airborne Hazard Center of Excellence has done any thoughts with regards to that. For me, it's really the size or a temporal determination or a determination based on exposure. Dr. Falvo?
Sure, thanks, Dr. Hastings. I think what our priority is and what our responsibility is to put that VA data, the data within the registry, to use for veterans. And so I think that's really where we look towards the committee to see, are there opportunities that we may be overlooking or ways that we can enhance our analysis to put that data that the veteran spent time completing and filling out that registry to good use. So not to turn that back, or what we call this upwards delegate, Dr. Savitz, I don't mean it that way. But I think that's really one of the things we're looking for from the committee.
Yeah, no, again, and that's fair. I mean, it's our charge is to make that recommendation, and we're just trying, it's helpful to sort of get a sense for the kinds of criteria that the VA would be looking at to ask the question of is continuing it's still useful or not, and that's I think that's helpful.
One of the other parameters that we would look at is if we have a fully functional ILR, would that be able to take the place of the registry, because it would be a collection of everybody. It would also have the monitoring and exposure data available to us. So that is one of the other parameters. Would ILR be an acceptable alternative?
Good, thank you. Okay, I think unless the committee has any additional questions, Not seeing.
Dr. Savitz, can I throw just one more idea?
Of course.
You know, we spend a lot of time, you know, data sets and research and stuff too, but I think about the veteran going in and doing it, and didn't quite say this, but it's kind of a balance. You know, we could add 50 more questions and do this, and you know, hour time already. You know, some people may not understand the registry, and it's like, wow, why all these questions? I just want to put my name on the record. So somewhere there should be kind of like the happy balance that we get information, but think about the you know, the veterans' time also. So I just want to put that plug in that, you know, this is, you know, about the veterans. So.
Thank you. You know, that's helpful, because clearly there are multiple uses of the registry and multiple factors that we'll be considering in trying to make an assessment of whether it is the best tool for that particular function. And I was just trying to, and I think I've gotten, that's helpful information in thinking about the different functions that it has.
Dr. Savitz, we have one more question from Dr. Daniels.
Please, the final one.
Yeah, so just a quick clarification from Dr. Hastings about potentially thinking about kind of the ILR potentially replacing kind of the registry. So you had mentioned at some point there might be the ability to do kind of personal exposure monitoring. So are you thinking about it kind of as a replacement potentially when that would happen? Because to some extent of those that respond to the registry, it seems like it would be supplementing what would be an ILR without the personal exposure with kind of a self-reported, arguably flawed personal exposure. So I just want a clarification about that.
Absolutely. Right now, we have, of course, the registry self-reported data. We have ILR, which has a direct feed of who was where when with the monitoring that's done. I'm sort of going futuristic with the future of ILR. The plan is that in ILR's future, when we have wearable exposure monitoring, everything from an accelerometer in the helmet for head injuries to a medallion of some sort that may collect your exposure to airborne hazards and particulate matter. We're not there, but that is what ILR will be able to get down to in the future. It's looked at right now in the aggregate. In the future, it will be more individual. With the registry, we don't have either of those available. We are looking individually at seeing how we can match the registry with the ILR information, but that is not something that we have done. So ILR is, again, the best we have for monitoring. The future of it will be more individual monitoring.
Okay, great. That's helpful. Thank you.
That's a nice note to end on this optimistic, high-tech future where we will be able to hopefully do better than we are today. That's the goal. We need more. We need optimism these days, I'm afraid. So, anyway, let me thank Dr. Shuping. The whole VA team has been very helpful, and we look forward to embarking on this. I think it's obviously an important venture, and I am optimistic that we can provide information you'll find useful. So